Now, let's have a look here. This is called humerus bone. See this? This humerus bone is present in our upper limb, okay, in the arm area. This is the area, and this is the humerus bone, anterior view and the posterior view. Now let's know some of the important parts of humerus. This is upper end of the humerus, and this is called lower end of the humerus. Upper end has got head. This is head of the humerus, which is very smooth in appearance. Now, why this head is smooth? What's the reason?
Fixed in the
Because it is present in the clinate.
It is
Fixed
in the clinoid
cavity. Present in the clinate cavity.
Exactly, exactly. Because it forms shoulder joint. It's a part of the joint. Okay, it is present inside the cavity of the joint, and it is present inside the glenoid cavity. Absolutely. So this is head of the humerus. Now you can see one slightly constricted part. This is called anatomical neck of the humerus. Anatomical neck. But please mind one important point. Surgical neck and anatomical neck are not the same thing. This is surgical neck. See this? This area is called surgical neck. So it is way inferior to the anatomical neck. Now we need to identify the greater tubercle and the lesser tubercle of the humerus, which is very nicely shown here. Greater tubercle and lesser tubercle. In some of the book, it is also written as greater and lesser tuberosity. It's the same thing. There is a small groove in between the tubercle. This is called intertubercular groove. See this? There is a deltoid tuberosity. Okay, there's a slight elevation on the shaft anterior side. This is deltoid tuberosity, where deltoid muscle is inserted. Now let's talk about the lower end. See this. Okay, so this is the condyles of the humerus. Okay, condyles, and these condyles have smaller part which are called medial epicondyle and lateral epicondyle. This is lateral epicondyle, this is medial epicondyle. Here is medial and here is lateral. This is called supracondylar part of the humerus. It is very commonly fractured in the children. Very commonly fractured. Now, this particular part which is present in the lower end of the humerus is called trochlea. Trochlea, and this is called capitulum. Trochlea and capitulum. Trochlea, okay, is attached with which bone? Which bone?
Ulna. Ulna.
Are you sure it's ulna? Capitulum. Capitulum is
Radius.
radius bone.
Capitulum with radius. Trochlea with ulna.
Exactly. Capitulum with head of the radius. Capitulum is with the head of the radius. Now, how I remember that? Remember caput. Okay, it sounds like caput. So the meaning of the caput is head. Head of the radius. Capitulum. Trochlea with the ulna. Especially, okay, there is a fossa, which is called olecranon fossa of the ulna, and that is connected with the trochlea. And this is the posterior view. See this? Okay, there is a trochlea you can see, and this is the olecranon fossa. This is called coronoid fossa. The upper end of the ulna has got two important part. The anterior is called coronoid process. The posterior is called olecranon process. This coronoid process of the ulna, okay, fits here in the coronoid fossa of the humerus, and olecranon process of the ulna fits onto the olecranon fossa of the humerus. So these are some of the important points. One more important thing before I move further, this is a radial groove. This radial groove is the site for radial nerve, and radial nerve is very commonly damaged at this site. We'll talk about radial nerve later on. Now, with this information, let's enter into the fracture of humerus. Fracture of humerus is discussed under three important types of fracture. One is fracture of proximal humerus, then shaft of the humerus fracture, and then distal humerus fracture. Okay, these are the three important types. Proximal humerus fracture includes surgical and anatomical neck fracture, and sometimes even greater and lesser tubercle are also fractured there. So that area, the proximal or upper part of the humerus, is fractured here. Shaft is the middle one, and distal part of the humerus can be fractured, which is supracondylar fracture. If any question is asked from this topic, let me clarify you right in the beginning. The question comes from supracondylar fracture of the humerus because of a lot of complication which it leads to. Now, let's start with proximal humeral fracture, and this is the mechanism of injury. In the young person, there is high energy trauma, mainly caused by road traffic accident or motor vehicle collision. Motor vehicle collision, a road traffic accident, you can say, very severe type of trauma. In elderly people, if they fall from a standing height, not from a very tall, place or a high area, they just may fall from a standing height by fall on outstretched hand. So this fall on outstretched hand, this is a very commonly used short form. I already talked about this. And why it happens, why they easily break their bone even if they fall from a standing height, because their bone is already osteoporotic in a post-menopausal woman as well as very old male. Regarding the clinical features of proximal humeral fracture, there would be pain and tenderness. Naturally, this is common in all type of fractures. There may be deformity in case of severe fracture, deformity because of displacement, and during examination you may get swelling. There is a painful range of motion. There may be bruise which extends down the arm. So these all are different clinical features. Some clues would be there. Now, one important point before we move further is anatomical neck fracture disrupt the blood supply to the humeral head, and the humeral head may suffer from avascular necrosis. Avascular necrosis. If the head doesn't get enough blood flow or blood supply, it will die. It will develop necrosis. That is called avascular necrosis. Okay, this is another commonly used short form, AVN, avascular necrosis. Now let's see some of the schematic diagram. See this. What can you see here? This is the head of the humerus. Here is the anatomical neck. The fracture is going right through the anatomical neck. At the same time, greater tubercle or greater tuberosity and lesser tuberosity are also fractured. Okay, so we can see 4 pieces here: 1, 2, 3, and 4. So 4 pieces of the fracture can be easily identified in this diagram. On the other hand, this is called surgical neck fracture. See this transverse type of fracture through the surgical neck of the humerus. Now, these are the different mechanism of injury in case of proximal humeral fractures. You can clearly see here, this is called fall on outstretched hand. Fall on outstretched hand. It exactly looks like this. This is an epileptic patient. Along with shoulder dislocation, even proximal humeral fracture can occur there. Especially the tubercle fracture is common. This may be electrocution or electrical shock type of injury. And what can you see on this X-ray? All of you, please focus here. What can you see here?
Fracture of humerus, sir.
Exactly. You can say fracture of proximal part of the humerus near the surgical neck. Okay, this is fracture near the surgical neck. A clear-cut fracture with a bit of displacement as well. Now, another important concept you need to know here is What are the muscle forces that act in humeral head fracture? So because of this muscle forces action, there is a displacement occurring. The supraspinatus and the infraspinatus muscle, which are a member of the rotator cuff. These are the member of the rotator cuff muscle, supraspinatus and infraspinatus. They pull the greater tuberosity superiorly. So if greater tuberosity is fractured, it will be displaced superiorly. Subscapularis, another member of the rotator cuff, pulls the lesser tuberosity medially. Now, lesser tuberosity or tubercle is displaced medially, and pectoralis major adducts the shaft medially. Okay, adducts the shaft medially. This is shaft means shaft of the humerus because pectoralis major is attached there. And what is adduction? What do you mean by adduction?
Going towards the
Going towards
Medial
midline.
going towards the medial.
Very good. Excellent. Going towards the midline or going towards medially is called adduction. Abduction is opposite to that. Now, the same concept which you are learning now is shown in the picture form. Supraspinatus muscle, infraspinatus muscle, teres minor, and subscapularis is anterior. Okay, and this is subscapularis. This is front view. See this front view, isn't it? And these are different muscles of our arm. Okay, different muscles of the arm, biceps and brachialis, and coracobrachialis also. So all these muscles are here. Now, what investigation you like to do in case of proximal humeral fracture? The first and the most important investigation is X-ray. Okay, X-ray. You take that X-ray quickly if there is a suspicion of fracture. At the same time, you test axillary nerve function, whether it is intact or not. Every student can answer this at this moment, how we test the axillary nerve. You test for deltoid muscle contraction. At the same time, there is a sensation or sensory examination also. We have to check the pain, touch, and temperature sensation over the skin in deltoid muscle, especially a little bit inferior region of the deltoid. That is called regiment badge area. These are the two important tests we can do. X-ray can be taken anteroposterior view, transscapular view, or axillary view. Epi and lateral or axillary view are quite common. CT scan can be taken if you are suspecting some complicated type of fracture. For example, there are multiple pieces you are suspecting, or if there is involvement of the shoulder joint along with proximal humeral fracture, then CT scan is a good investigation. Now, all of you, please focus on the slide. What can you see here? See this? Which fracture? You have to identify the fracture here, okay? This area, see this? There are lots of, fracture here. Look at this, fracture line with a displacement of the bone. The inferior fragment is displaced superiorly here. It has already gone up. Okay, look at this area. So we can say there is a fracture at the surgical neck of the humerus with displacement of the lower fragment. Displacement of the lower fragment, you can say that, and multiple other fractures also. Greater tubercle and lesser tubercle are also fractured here. See this? This is a clear-cut case of greater tubercle fracture. See this piece. Okay. Let's move on. This is called 3D reconstruction of CT scan. Now, 3D reconstruction of CT scan, and this is a excellent, what should I say? The excellent, thing these days. This is the way by which we can easily identify even a difficult type of fracture. If X-ray cannot pick the fracture line, but you strongly believe there is a fracture, then you have to go for CT and go for 3D reconstruction. See this? There's a fracture you can clearly see here. Okay, these are some other pieces. Now let's classify the proximal humeral fracture into different types. You can clearly see there are 4 fragments here. This is head. Okay, this is called articular surface or head of the humerus. This is the area of anatomical neck. Okay, anatomical neck. Here is greater tuberosity. It is lesser tuberosity, and it is the shaft of the humerus. So clearly, I can see 4 pieces here. The classification is based on 4 fracture segment. That's why we are constantly talking about those 4 fragments, and these are once again the articular segment, the greater tuberosity, lesser tuberosity, and the humeral shaft. This classification describes only displaced segment which are defined as 1 centimeter displacement, or if there is angulation of 45 degree. Okay, that usually happens in the displaced fracture. Now let's talk about this important type of classification. Please focus here. This is called near classification, and this near classification is based on 4 fracture fragments. And regarding the displacement, just now you saw this statement: displacement should be more than 1 centimeter and angulation should be more than 45 degree. Okay, now because of this displacement and angulation, or because of the near classification, the fractures of proximal part of the humerus is classified under 1-part fracture, 2-part fracture, 3-part fracture, or 4-part fracture. Very easy classification, and these are based on how many pieces of the fracture fragments are there. 1-part fracture means any of the 4 parts with non-displaced, they are not displaced, but 1 out of those 4, okay, pieces is fractured, only 1, either greater tuberosity, either lesser tuberosity, humeral head, or the shaft. 2-part fracture, any of the 4 part with 1 displaced. 3-part, there is a displaced fracture of the surgical neck and displaced greater tuberosity or lesser tuberosity fracture. And if we count, there are 3 pieces now. And 4-part fracture means if you count, there are 4 pieces. That's the meaning. Okay, see here. Now, what is that pieces we are talking about? Okay, this makes you feel quite confident regarding this concept. 1 part, there is only a fracture line. There is no displacement, only fracture line. 2-part, see this, there is displacement. This is 1 part, this is 2 part. Okay, 2 pieces, isn't it? I can see. 3-part, 1, 2, and 3. And 4-part, 1, 2, 3, and 4. So quite an easy type of classification. Near classification of proximal fracture of humerus. Now, what is the treatment then? According to this classification, the treatment is provided. In case of minimally displaced fracture, we just provide sling immobilization followed by early movement. You put a sling there and you ask the patient, don't move that part. Okay, after the patient doesn't have any pain, then early movement is necessary. In case of 2-part fracture, what's the treatment? If anatomical neck fracture is there, it likely require ORIF, open reduction and internal fixation, because there is a high incidence of osteonecrosis, also known as avascular necrosis of head of the humerus. Okay, avascular necrosis of head of humerus. In case of surgical neck fracture that are minimally displaced, it can be treated conservatively. Now, what is conservative treatment means? What is conservative treatment means in this case?
According to the sign and symptoms treat.
The symptomatic treatment.
Conservative treatment here means, okay, it is not a surgical type of treatment. You don't open that area. You don't do ORIF. Either you apply some cast there, okay, some slab there, just some sling, give painkiller to the patient, ask the patient don't move that area, okay. This is called conservative therapy, and it works in case of surgical neck fracture. But if it is displaced very badly, then it requires ORIF, open reduction and internal fixation. In case of three-part fracture, due to disruption of opposing muscle forces, these are quite unstable fracture. Remember those greater and lesser tubercle, they after the fracture they really displaced because of the pulling of the muscle. So conservative treatment or closed treatment is difficult. We have to go for ORIF, open reduction, internal fixation. And four-part fracture is the most serious among them all. Okay, so there is a we have to take this patient for ORIF. Usually conservative management fails here. We don't even go for that. So ORIF is done in the young, and hemiarthroplasty is done in the elderly people and those with severe comminuted fracture. Comminuted means multiple pieces. We all know the meaning. But what is hemiarthroplasty? What do you mean by that? Anyone?
Replacement with artificial joints.
Good, Sadat. Anybody else? So which part of the joint you are going to replace here? Hemi means half, remember that. I'm talking about shoulder joint, right? So there are two parts of the shoulder joint. One is glenoid cavity, another is head of the humerus. There is no problem with glenoid cavity there. So you don't even touch that glenoid cavity. But head of the humerus probably is badly fractured. So you replace that head of the humerus, okay, artificially. This is known as hemiarthroplasty. The four-part fracture has a high rate of avascular necrosis. So treatment has to be done in time. If we do the treatment in time, probably the chances of avascular necrosis can be minimized. But once it has happened already, isn't it? And later on, we have to manage some of the complications which may occur now. Like you have learned this lesson before. What is the important complication of avascular necrosis of the head? What happens?
It will be persistent.
Anatomical.
Anatomical neck fracture, so the artery goes to the anatomical neck of the head.
Artery will compromise, sir. The blood supply will compromise to the head,
No, you
head of the humerus.
wait. You already know that. So that's why it is known as avascular necrosis, isn't it? Blood supply is already disrupted. Okay, we are already moved away from that status. But what happens in the long term if we do not treat this in time? The head is already dead. What other complication may arise there? That's the question.
Paralysis occur.
Joint deformity.
Infection occur.
Infections and the recurrence of
There will be
dislocation.
neurovascular damage.
Okay, so I'm getting different answers. Let me clarify that after the break.
Immobility.
So I was asking you a question, okay, before the break, and that was, in case of vascular necrosis of head of the humerus, or because of vascular necrosis of a part of a joint, actually, what complication can occur later on? And the answer is the joint will be deformed. That head is quite weak after it is dead. It becomes deformed, number one, and number two, in a long term, it may lead to osteoarthritis. Never forget it. Osteoarthritis. That is degenerative disease of the joint. And that joint become a very painful one. Now, these are the surgical management or open reduction and internal fixation in case of proximal fracture of the humerus. You can clearly see here, this is a plate and these are the screws, plate and screws which are applied here, and you can clearly see the fracture line, isn't it? So see here, this is the rush nail insertion. This is a type of intramedullary nail. Okay, it is inserted to stable this fracture. This is known as K-wire insertion or fixation, intramedullary K-wire fixation. You can clearly see here, this is a very bad looking fracture. So it is reaching up to the head. These all are different types of open reduction and internal fixation. Now see here, what are the complications of humeral head fracture? So many times we talked about this, so let's revise it again. Early complication would be neurovascular injury, and the main nerve which is injured is axillary nerve. This axillary nerve may be injured or damaged both from the injury as well as from the ORIF surgery which we have done to fix the fracture. And after the surgery, the surgeon will definitely check for the function of axillary nerve, that is the functions of the deltoid muscle or the cutaneous innervation at the inferior region of the deltoid. Regarding the late complication, malunion, if we go for the conservative type of management, malunion may occur. Stiffness of the joint is very common because it is quite near to the joint, and avascular necrosis, discussed so many times. It occurs in 10% of 3-part fracture and 20% of 4-part fracture. You don't need to remember this percentage, these are very difficult to remember, but just know avascular necrosis can occur in this type of fractures. Okay, now with this complication discussion, let's move on. Let's talk about another part of the humerus fracture, that is shaft fracture, humeral shaft fractures. Let's start with this X-ray here. You can clearly see right here, okay, in this area. What type of fracture is this? Can you classify this fracture? Because you have done that before.
Middle shaft.
Middle, sir.
Very good. You can say this is a fracture shaft of the humerus, comminuted type of fracture, because we can see multiple pieces. Comminuted fracture of the shaft of humerus. Excellent. And already the POP cast is applied there. See this? I can see the POP cast on the side. Here is another fracture shaft of the humerus. So what is the mechanism of injury here? The mechanism of injury is usually the direct trauma, and this trauma has to be a severe one. Okay, severe one, especially if the person is young, like a motor vehicle accident or motor vehicle collision or road traffic accident. Sometimes indirect trauma like fall on an outstretched hand can be there, and this happens mainly in the osteoporotic individual where the bone is already having some disorder. Another example of pathological fracture here. The fracture pattern depends on stress applied. So what type of stress or what type of injury the person is suffering from, accordingly the fracture patterns would be there. And these are the different pattern of the fracture: compressive fracture, bending type of fracture, torsional, okay, torsion and bending. So these are the different type of stress. So accordingly the fracture pattern will be there. Compressive fracture can lead to proximal or distal humerus fracture. Bending type of force can lead to transverse fracture of the shaft. Torsion can lead to spiral fracture of the shaft, a bit of twisting. And torsion and bending can lead to oblique type of fracture. There may be a small butterfly fragment, means floating fragment in the middle. Okay, one small extra fragment may be there. So these are different fracture pattern in case of humeral shaft fracture. And what is the explanation? It depends on what type of stress or what type of injury is applied there. Let's move on. Now look at this. Now among these different type of fracture we have just seen, which one is this? Which one is this?
Spiral fracture. Spiral fracture.
Spiral.
Spiral.
Like a spiral. Spiral fracture.
Exactly. It looks like a spiral fracture. Excellent. This is a spiral fracture. Very good. Because this is twisted and it is rotated also. This is a spiral fracture of the shaft. Now, how to clinically evaluate this humeral shaft fracture? So, as always, we start from the history taking. What type of injury was there? What the person was doing during that time? How forceful was the impact and all those things? Then we physically examine the patient. So patient usually present with pain in that area, swelling, and deformity. These are classical symptoms of any fracture. At the same time, you need to examine the neurovascular bundle, and one of the most important nerve which may be damaged in this situation is radial nerve now. It is no more axillary nerve. Axillary nerve is already gone, towards the surgical neck of the humerus. This is radial nerve. This radial nerve lies in close proximity to the shaft of the humerus, and it can be injured during shaft fracture. And when radial nerve is injured or damaged, there will be wrist drop. There will be wrist drop. Now everybody should try to understand what is the meaning of wrist drop. That means the wrist cannot be extended now. The flexor compartment is normal because it is not supplied by radial nerve, it is supplied by median and ulnar nerve. They are doing their job. That's why the wrist is flexed and it cannot be extended. It remains flexed most of the time. This is known as wrist drop. This is a very important point. With this single point, we can suspect there is a radial nerve injury. So wrist drop. Another is sensory impairment on the dorsum of the hand. This is also supplied by radial nerve, except the fourth finger and the fifth finger. A little bit part of the dorsal surface of fifth finger, and the part of the fourth finger which is facing the fifth finger. Apart from these areas, most of the other part of the dorsal of the hand is supplied by radial nerve. This is sensory involvement we are talking. Those two areas which are listed as exception are supplied by ulnar nerve. See this? This is the radial nerve. Now, there is one type of humeral shaft fracture which is known as Holstein-Lewis fracture. Holstein-Lewis fracture, that means the fracture occurred at the distal shaft of the humerus, or distal 1/3 part of the humeral fracture. And the important point regarding this is it may entrap or lacerate the radial nerve very badly as the fracture passes through the intermuscular septum. The radial nerve may be entrapped between the fractured pieces and it can be severely injured or damaged. So just try to remember the name. Holstein-Lewis fracture occur at the distal 1/3 of the humeral shaft. Now, as always, for the investigation, we like to do X-ray. AP and lateral view of the humerus will give you the diagnosis. Sometimes you can go for traction radiograph. This traction radiograph may be indicated for hard to classify secondary to severe displacement or a lot of comminuted fracture. Means complicated type of fracture. If there is a serious type of displacement, and we do not know what type of fracture is this, it is hard for us to classify, then give a traction. Ask a person to pull the distal fragment and during that time take the X-ray. It will be very easy to identify which type of fracture is there. Okay. Now let's see some of the X-rays here. Okay. All of you, please focus here again. See this? There's a fracture here. It again looks like a spiral type of fracture, isn't it? Spiral fracture. Now see this. This is a very bad looking fracture. This is spiral fracture with a butterfly segment. This is called a butterfly segment here. This is a bad looking type of fracture. Now, let's manage humeral shaft fracture. How do we go for the treatment? In general, humeral shaft fracture are treated non-operatively or conservatively. And what type of conservative management we usually go for? Okay, sometimes you have to reduce the fracture, and some other time you don't even have to reduce it. Reduction is not always necessary. You know that principle because we have taken a lot of time, okay, to discuss about the principles of fracture management. Reduction is only necessary if there is displacement of the fracture, and if that displacement is, okay, unsatisfactory. We cannot accept that displacement. It is unacceptable type of displacement. Then only reduction is done. Otherwise, some minor type of displacement are accepted. Now see there, we can accept deformity due to compensatory range of motion of the shoulder. Shoulder is a very mobile joint, so that range of motion may compensate minor type of deformity like 20 degrees of anterior angulation, 30 degrees of varus angulation, and up to 3 centimeters of shortening in the shaft of the humerus are acceptable deformity. And you don't need to go for the reduction in this type of situation. You simply go for the treatment. And the treatment is hanging cast. This is known as hanging cast treatment. Now, what do you mean by that? We apply a cast there, okay, and that cast, along with the weight of the arm, okay, along with the gravitational force, will apply constant traction across the fracture site, and at the same time you apply collar and cuff sling to immobilize the site. Okay, this is the management. Hanging cast with collar and cuff sling immobilization is the management of most of the fracture shaft of the humerus. Now later on, when the swelling subside, okay, you replace that hanging cast with Sarmiento functional brace. This is a type of brace which will replace the cast later on. Now let me show you how that hanging cast and what that functional brace looks like. See this? This is a hanging cast. So where the hanging cast is applied, especially on the forearm. Inferior part of the arm is also included, elbow joint is also included, and whole of the forearm till the wrist area is included. So it is supported by a sling. You can clearly see here, and this acts like a constant traction force which will help in the reduction of the fracture and healing for it. Hanging cast. Now after swelling subside, okay, and patient feels a bit better, this hanging cast is replaced by this functional brace, Sarmiento functional brace. It will immobilize that area, and then this is much easier than the hanging cast for the patient. Now, all of you, please pay attention at this picture. So take a bit of time. What can you see here? This is a fracture shaft of the humerus. See this on day 1. Okay, day 1 of the fracture, day 4 of the fracture, day 7 of the fracture, 2 weeks, and 6 months. Now at 6 months, I even cannot see the fracture line. Okay, I have to look very carefully. Where was the original fracture there? At 2 weeks, I can see the callus there. Okay, though this is not a very strong type of callus. Here, this is a hematoma with a bit of callus start to form. Okay. and here there is no callus formation till that time. This is very early, and this is a fracture. So these are the different stages of the fracture healing. Now, what are the indication for ORIF, okay, or the operative management? Now, most of the time we go for conservative treatment, like a hanging cast, which is replaced by a functional brace later on. But in some situation, we have to go for ORIF quite early. What are those? One is open fracture or compound fracture. This is a complicated type of fracture, and usually we have to go for ORIF. So open fracture. Second, neurovascular injury, radial nerve damage, okay, brachial artery injury. So we have to go for the open reduction and internal fixation. At the same time, explore that neurovascular bundle. Third, unacceptable fracture alignment. The displacement is more than the acceptable range. Multiple trauma in the patient, okay, polytrauma we say. Segmental type of fracture, a segment is separated. Pathological fracture, we usually go for open reduction and internal fixation. And floating elbow. Okay. The meaning of floating elbow is there is simultaneous unstable humeral and forearm fracture at the same time. This is the result of multiple trauma or severe type of injury like road traffic accident. Forearm fracture means the radius and ulna fracture, these are the forearm bone, isn't it? As well as unstable humeral fracture. And intra-articular fracture, there is a high chance of avascular necrosis. There is high chance of long-term complication. So better to fix that part quite stably. So these are the different indications. Now you already know this is known as ORIF, but which type of ORIF we like to do here? There are different types. Plating, which is most common. Intramedullary rod insertion, as well as external fixation. External fixation is done in which situation? Can you choose one of the situation where external fixation is done from this list? Anybody? Which is?
Compound, open fracture.
Open fracture.
Open fracture.
Excellent answer. Very good. Excellent. This is open or compound fracture. I've clearly told you during that time, open fracture or compound fracture is it has a high chance of contamination. So you don't put anything inside. Okay, it may get infected. Rather, we fix this type of fracture from the external side. So external fixation. And in case of closed fracture and all these indication, you can easily go for plating or intramedullary rod insertion. Now look at this X-ray once again. So this is the plating. Okay. This is a plating. Very nice, X-ray plating with a lot of screws there. Excellent type of fracture management. And this is the another one. This is intramedullary K-wire fixation. Okay, intramedullary K-wire fixation. Intramedullary K-wire is a bit thinner than the intramedullary rod. So it depends on the orthopedic surgeon what they feel they can put it there. Okay, and the principle is you don't open the fracture site. It is inserted either from the inferior part or the superior part of the humerus fracture. It is one of the modality to treat long bone fracture actually. Now let's talk about the important part of this lecture. What are the specific complications of humeral shaft fracture? And I'll focus mainly on radial nerve here. The important one is radial nerve palsy. This is means damage of the radial nerve. Expect the spontaneous recovery in 3 to 4 months. Otherwise, send the patient for electromyography, EMG, electromyography, because that radial nerve is supplying so many muscles there. We'll talk about that a bit later. And we can go for electromyography just to know whether it is innervated by radial nerve or not. Another important complication is non-union, especially in the middle 1/3 of the fracture, probably because of the lack of blood supply there. Decrease range of motion, okay, of the shoulder joint or the elbow joint. Shoulder joint is more important. And compartment syndrome. This compartment syndrome is not very common in the arm. It is more common in the forearm or the leg fractures. Okay, so the important one are radial nerve injury, and sometimes brachial artery injury can also occur, but brachial artery is also commonly injured in supracondylar fracture of the humerus rather than shaft of the humeral fracture. Now, let's focus ourselves a bit about radial nerve injury, and this is an important question which is asked to the students. So let's start from the origin of radial nerve. Now, all of you, please focus on this, picture and try to find out from where radial nerve has originated. Okay, take a bit of time, please. See this. This is brachial plexus. Okay, brachial plexus. So let's take a bit of opportunity to talk something about brachial plexus here. The brachial plexus is formed by C5, C6, C7, C8, and T1. Okay, these are the roots. Okay, these are the roots which are coming from the spinal cord, from the cervical part of the spinal cord. And remember, if we talk about the spinal nerve, let me clarify once again. The spinal nerve is formed by the union of dorsal and ventral root. After the spinal nerve is formed, that spinal nerve immediately divides into two branches, dorsal ramus and ventral ramus. Now, one small question here. This brachial plexus is formed by dorsal ramus or ventral ramus? Yes? Which one?
Ventral ramus.
Exactly. Always ventral ramus. Dorsal ramus do not contribute at all. Dorsal ramus goes on the back side and they supply the structure there, okay, on the posterior aspect of our body. All these are formed by ventral ramus. So the C5, C6, C7, C8, and T1 are actually the ventral ramus of those spinal nerve. Now that's very clear. So C5 and C6 combine together to form superior or upper trunk. This is the trunk, upper trunk. C7 continue as a middle trunk, and C8 and T1 fuse together to form lower trunk or the inferior trunk. So upper trunk or superior trunk, middle trunk, and inferior or the lower trunk. Now these three trunks have two division on each of the trunk. Superior or upper trunk has got two division, anterior and posterior division. Middle trunk also has two division, anterior and posterior, and inferior trunk also has two division, anterior as well as posterior. Now these anterior or posterior division will fuse with each other to form the cords of the brachial plexus. Now look very carefully here. See this. Okay, this is anterior division. See this, anterior division and anterior division from the lateral cord. Okay, so here posterior division. Okay, all posterior division will combine together to form posterior cord, and similarly medial cord is formed. Now these are the three terminal cords, and from each of these cord a lot of branches are coming out from the brachial plexus. Very important question in the examination. Please don't think only the anatomy teacher will ask this question. Okay, any of the other teacher can ask this question in the related topics. So I need to be sure about this preparation. Now at this moment, okay, I don't want to deviate myself. We just focus from where the radial nerve is arising. Now Where? What is the origin of radial nerve? Just see there an answer. From where?
Posterior.
Posterior cord.
Posterior.
Posterior cord.
Exactly, posterior cord. See, this is the radial nerve. Okay, it is a very big nerve. Actually, the biggest nerve which comes out from the brachial plexus, the thickest one, radial nerve, and it has got the root value of C5, C6, C7, C8, and T1. Now, why is that? Okay, why it has the root value of all the components? The answer is provided by here. If you trace it, just trace and go upward. See this. Posterior cord has the component of all three divisions, and these divisions are coming from all the trunks. That's why it has all the component there. Now we know what is the origin of this radial nerve. Now let's talk about, please listen carefully, let's talk about how this radial nerve goes distally. This radial nerve enters into the arm now. It goes on the back side of the arm, which is known as posterior compartment of the arm. We have got a very important muscle there on the posterior compartment of the arm. What is the name of that muscle?
Tricep muscle. Tricep muscles.
Very good. Triceps muscle. Triceps. Okay. This triceps muscle is mainly supplied by radial nerve. It is mainly supplied by radial nerve. There is one small muscle which is known as anconeus, which is near to the elbow region on the posterior aspect, that is also supplied by radial nerve. So these are the two important muscles in the arm area supplied by radial nerve. Now, in the middle of the arm, near the shaft, middle shaft of the humerus, you have seen that picture earlier. The radial nerve comes anteriorly from the posterior side, and that area is very commonly injured. Okay, during the radial nerve lesion, very commonly injured site, either because of fracture or because of the crutches which the patient uses exactly at that site. Okay, crutch injury we say. And sometimes a drunkard person or an alcoholic person, how they sleep, sometimes what happens, they are heavily boozed or heavily drunk, they just sleep on the chair, and when they sleep, they hang their arm or the upper limb from that chair, and throughout the night the radial nerve is compressed by the chair, and in the morning they can develop that wrist drop type of deformity. But this type of injury is not very serious because it's a neuropraxia type of injury, and radial nerve will regain its normal function very soon. So I'm just explaining you about the pathway of radial nerve there. In the lower part of the arm, in the anterior aspect, the radial nerve is present, and then it will divide into two branches, and it will enter into the forearm. Now, what are those two branches of the radial nerve now, which enters into the forearm? What are the names of those two nerves? Anybody? Yes. Posterior interosseous nerve. Very good. And
deep branch of radial nerve.
And you can say superficial branch, okay, or the cutaneous branch. Excellent answer. Posterior interosseous nerve, which is the deeper branch, and it gives supply to the muscles of the forearm. And superficial branch, this is the cutaneous branch, which supply the skin. Okay, it supplies the skin and the back of the hand. Now these are the branches of radial nerve. Now another question, okay, which may be asked to you: which muscles in forearm are supplied by radial nerve? So what is the answer? Which muscles?
Extensor
compartment of the forearm.
Extensor compartment.
muscle.
Very good.
Posterior compartment muscle.
Very good. That one point is more than enough. Extensor compartment or posterior compartment of the forearm is supplied by radial nerve. It belongs to radial nerve. And regarding the cutaneous sensation or the skin innervation, back of the hand is mainly supplied by radial nerve, except the back of little finger and adjacent side of the ring finger. So this much information you have to know when a question is asked from the radial nerve. Let's move on. Now, when radial nerve is damaged, the person will develop wrist drop. And this is what wrist drop looks like. See this? This is the flexion deformity. The person cannot extend the wrist, means the person cannot take the wrist upward because of paralysis of the muscles of the posterior compartment of the forearm. This action is not possible. But the flexor or anterior compartment muscles are normal because they are either supplied by median nerve or ulnar nerve. So this action is still possibility. This is known as wrist drop. Radial nerve injury is associated with fracture humerus in up to 12% of the time. Okay, 12% of the time. See this? So that's why we are talking it here. Almost 2/3 of the radial nerve fracture are neuropraxia, and around 1/3 are nerve laceration or transection. Now, I'm sure you still remember the meaning of this term. What is neuropraxia? What is neuropraxia?
Minor type of
Physiological
which can be
interruption
recovered.
of the nerve
Minor type of injury which can be recovered.
Nerve injury in which conduction of nerve is damaged.
Very good.
Only conduction of the
Excellent.
interruption.
All of the students, okay, I can clearly hear all of your answers. Very good way of answering. This is a very minor type of nerve injury where only the conduction is having problem. There is no structural damage to the nerve. This occurs because of compression or because of minor type of injury. And all these neuropraxia will recover ultimately. But another type of nerve injury are axonotomesis and neurotomesis. Now, axonotomesis will also recover, but neurotomesis, we need to do some surgical management. You need to suture the nerve quite early, okay? Then there is a chance of regeneration. Rather than regeneration, I use the term recovery here, okay? Nerve will not regenerate easily. So chance of recovery is there if we treat that neurotomesis or nerve transection in time. If the person ignore, then it will be permanently damaged. Now, how we manage it? What is the management of radial nerve injury? You see this? When radial nerve injury occurs in open fracture or compound fracture, we need to immediately explore it and then repair it if it is damaged. If it is not damaged badly, only neuropraxia type of injury, you don't need to repair it. Okay, that's why it is written plus minus repair. Open fracture are very commonly associated with neurovascular injury. Whereas in closed injury, they are treated conservatively. But in the beginning, you need to check what is the function of radial nerve there. Is it intact or not? And you know, all know how to check it. Okay. Later on, we have to go for nerve conduction study or nerve conduction velocity study. In last time we talked about Guillain-Barré syndrome, and that Guillain-Barré syndrome also will have this type of investigation, as well as electromyography. And if these are intact, then we mean the nerve has recovered or the nerve is not seriously damaged. Now look at this photograph or picture. What is happening to this person? Which side?
Drop.
Yes, which
Yes,
side?
wrist drop.
Wrist drop.
Exactly.
Right triangle.
Everybody can see this. Okay, so let me show you. This is called wrist drop. See this? This is a very typical picture, wrist drop. The other hand is fine. Okay, the other hand is absolutely normal. But here is the wrist drop. Probably this person is having radial nerve injury. We do not know what is the mechanism of this injury. It can be anything, and that can be easily diagnosed by history taking as well as physical examination. Now, some more point about the management. Recovery usually starts after a few days, but may take up to 9 months for full recovery. So it's a long duration for the full recovery to regain. And if no spontaneous recovery occurs in 12 weeks or 3 months, which is confirmed by nerve conduction study, NCS is nerve conduction study, is a short form, and electromyography, then exploration of the nerve should be carried out. Probably something is pressing that nerve there. Maybe a big callus is formed after the humerus, shaft of the humerus fracture. That callus is compressing the nerve, isn't it? Something like that. Maybe the nerve is trapped inside the callus. Maybe the nerve is trapped inside the fracture fragment. So all these things we need to explore if it doesn't recover completely in 12 weeks time. How I know there is no complete recovery? Two things. One, physical examination. Need to check the innervation site of radial nerve, that is dorsal surface of the hand. Another one, okay, ask the patient to move the wrist in different directions. All these things are there. And investigation wise, you need to go for nerve conduction study and electromyography. These are very specific tests for nerve function study.